Good morning students. Today we arrived at a new topic that is relevant to pulmonary system. Previously we had a discussion about cough types, how to treat, when to suspect serious pathologies, kind of those things. Actually we can say there is one entity within that cough, means coughing of blood. A specific terminology has been given for that thing, that is known as hemoptysis. Hemo means blood, tysis means cough related blood. Hemoptysis means simply nothing but expectorating blood from the lower respiratory tract. Clear? The word should be clear. So hemoptysis is nothing but, please remember these terms clearly because these are very important. Expectoration of blood from the lower respiratory tract. Expectoration from the lower respiratory tract, not from the upper respiratory tract. If it is coming from the upper respiratory tract, so when do you call upper respiratory tract? From the nose till the glottis, that is known as epistaxis. There might be some common etiologies as far as epistaxis and hemoptysis are concerned. Because hemoptysis is more sinister situation, we have to attach more emphasis on hemoptysis rather than epistaxis. So epistaxis from the nose, throat, or even biting of tongue, that is nothing but blood from the upper airways. So epistaxis from the upper airways, whereas hemoptysis is from the lower respiratory tract, LRT. So this is URT, this is LRT. On the other hand, one more term we should distinguish. Sometimes patients tell that he had vomited blood. So in such settings, specifically you have to ask the incident, that means that preceding event, whether you had cough at that time or simply vomiting. If so, what is the color? If the color is bright red and patient has cough, it is mostly hemoptysis. On the other hand, patient had got nausea, vomiting, retching, especially coffee grounds appearance, then that is hematemesis. This dark blood is because of admixture of HCl in our stomach with the hemoglobin. So coffee ground color is suggestive more of hematemesis rather than hemoptysis. But remember, patients are always not 100% sure. In such settings, thoroughly examine the patient. Look for both respiratory and GIT causes. Okay. There is one arbitrary cutoff for hemoptysis, whether it is life-threatening or not. If it is life-threatening, another term for that one is massive hemoptysis. Any blood that is coming out of lungs within an hour, that is more than 100 ml, it is labeled as massive hemoptysis. Please remember this thing, because we are not going on observing a patient for 24 hours or more than that for volume of blood that has been expectorated. So in an hour, if the expectorated blood is more than 100 ml, diagnose it as massive hemoptysis. Similarly, if it is there, previous history is there, reliable, any blood coming extra, that is more than 150 ml within 24 hours, you can label it as massive hemoptysis. After all, this blood is quite important, even 150 ml per 24 hours, because we have got around 5 liters of blood only. That means 5000 ml. After in that, already 150 ml has gone and patient has attended our hospital and still having hemoptysis. So if you suspect these two, more than 100 ml per hour or with history of more than 150 ml in previous 24 hours at home, immediately evaluate for massive hemoptysis. Okay, now we'll discuss pathophysiology of hemoptysis. You know, lung has got a dual blood supply, just like heart. One is high pressure, low volume, that is high pressure is bronchial arteries, because they are derived from the systemic circulation from aorta. So the pressure is, blood pressure is systemic, 120/80 or much more than that. Okay. Second one is low pressure, high volume, that is pulmonary. vessels, pulmonary vessels. If you see the blood pressure of pulmonary vasculature is, it is around 1/4 to 1/5 of systemic pressures. Systolic is around 25, diastolic is around 10. And you know mean arterial pressure. Mean arterial pressure is the average of systolic and diastolic. As far as pulmonary circulation is concerned, I will tell an important clinical point. If mean arterial pressure, MAP, not systolic or diastolic, mean arterial pressure in pulmonary vasculature is more than 20 millimeters of mercury, then it is labeled as pulmonary arterial hypertension, typically with aid of 2D echocardiography. Okay, remember this point. This will impress your professor. Mean arterial pressure of 20 or more than that is a diagnostic of pulmonary arterial hypertension. If at all there is shunt reversal from right to left. Okay, that is different thing. We will discuss that thing in cardiology in future. So as far as hemoptysis is concerned, majority of the cases are because of bronchial vessel erosions or rupture, or you can say sometimes aneurysm formation, kind of those things. So especially in massive hemoptysis, because it is a high pressure situation, there is lot amount of blood that is coming out of lower respiratory tract. So unless proved otherwise, in hemoptysis always suspect bronchial vessels as culprits. Okay. So are you clear about the pathophysiology of hemoptysis? Most of the times it is because of the bronchial vessel involvement. Coming to etiologies of hemoptysis, I have broadly divided into 4 categories. Infections can be viral, bacterial, fungal, kind of those things. Vascular, aneurysms, shunts, kind of those things. Malignancies, either primary or metastatic. Last one is mechanical, especially in the setting of modern usage of anticoagulants and antiplatelets. If some procedure is carried out in lungs or heart, they can lead to hemoptysis. Let's go to next slide. So infections. Most common cause of community acquired pneumonia is viral, but unfortunately bacteria may supersede, means secondary bacterial infections. Especially these big 3 are very important. What are they? Streptococcus pneumoniae. Streptococcus pneumoniae. Second one is Haemophilus influenzae. Streptococcus pneumoniae, Haemophilus influenzae. Third one is Moraxella catarrhalis. Moraxella catarrhalis. These are known as big 3 for usual community acquired pneumonias. And most of the times they are beta lactamase producing. That's why in such settings we use amoxicillin clavulanate combination. And another thing, especially in developing countries like us, tuberculosis, either Mycobacterium tuberculosis or atypical mycobacteria. There is one entity known as massive hemoptysis in the setting of tuberculosis, that is known as Rasmussen aneurysm. In long-standing cavitary tuberculosis, you know why cavities form in tuberculosis? That is because of granulomatous inflammation. Second one is compression of these airways by tuberculosis induced lymphadenopathy. Tuberculosis related or induced lymphadenopathy. So they can lead to proliferation of mycobacteria in such areas. Over a period of time, these mycobacteria, because they stimulate cell-mediated immune injury, they release interferon gamma kind of those things. Downstream, they release phospholipases, interferon gamma downstream, that is apolipoprotein related, apolipoprotein lipases. They destroy these connective tissues of lungs. Whenever the supporting structures of pulmonary parenchyma are destroyed, they are prone for cavity formation. So surrounding this cavity, there might be, hear carefully, this is very important, here the culprit is not bronchial vessel, here the culprit is low pressure but important one, that is pulmonary artery. Its aneurysm develops because supporting structure is lost, vessel gets dilated, ectatic, and it grows into this cavity. Okay, once inside the cavity, because of violent cough or sometimes spontaneously, the vessel wall weakens, tunica adventitia, media, kind of those things, and suddenly rupture into this cavity, producing massive amount of blood in the lower respiratory tract. That is nothing but hemoptysis. So Rasmussen aneurysm is historical importance because it was discovered by Valdemar Rasmussen way back in 1868. From that time, this has been present in all our textbooks in the honor of that physician who has diagnosed that thing. Though I am telling hemoptysis in tuberculosis happens because of bronchial vessel involvement, but classical description initially was because of cavity relation. This is known as Rasmussen aneurysm, and this is because of pulmonary artery, not bronchial arteries. Please remember, I am stressing this point again and again. Okay. By the way, you know this interesting point, how cavities form, especially lung cavities in tuberculosis. Initially, there was a theory that it is because of macrophages, but it is not so. Whenever there is inflammation in the setting of tuberculosis, there are two drivers. One is class 1 interferon. Second one is class 2 interferons. Class 1 interferons already we have touched upon this topic, alpha and beta. Type 2 interferons are gamma. Whereas alpha, beta are by neutrophils, gamma is from macrophages. Okay. Whenever there is a mycobacterium insult, our host tissue responds in such a way that there is a flooding of these alpha beta interferons from neutrophils. These will go on destroying this bacteria and also host tissues, including our lung parenchyma. At the same time, with the help of Th1, that is delayed hyperresponsive axis, macrophages are recruited, and these macrophages secrete interferon gamma to contain this overwhelming tissue destruction by alpha and beta. So essentially, these type 1 interferons and type 2 interferons are antagonistic. Whatever we are measuring in our previously discussed, that IgRA assay is function of macrophages, IGRA, which is actually protective against the cavity formation. So when this is overwhelmed because of this neutrophil contents, entire tissue gets necrosed, laden with dead bacteria, I mean mycobacteria, and that is known as caseum, caseum, caseous necrosis. So over a period of time, because this tissue is now devoid of blood supply, that means becomes avascular, nothing remains. So it becomes a cavity. It often happens in upper lobes and middle lobes because of better aeration there. Better aeration because of our tuberculosis bacteria is a obligate aerobe. It always prefers oxygen because it can't survive for long in this dungeon, means anaerobic host environment caseum. Actually, it is a host response to contain tuberculosis, but it always craves for oxygen. That's why whenever in the cavity, when there is a rupture because of caseous necrosis, millions of this bacteria will be exposed to air, that is oxygen in the air, and especially in upper lobes, they will survive for years together. So in this way, tuberculosis bacilli try to survive in humans. Okay, got the point? So far we discussed about pathogenesis of cavity formation as far as Mycobacterium tuberculosis is concerned. Okay. Second one is, please remember, cavity formation is not specific for our tuberculosis. Many agents can cause similar picture, like most of these fungi, like Rhizopus, Mucormycosis, kind of those things, Nocardia, and Aspergillus. Aspergillus can cause a fungal wall formation in these cavities, further eroding this cavity and can lead to hemoptysis. So any cavity lesion with hemoptysis, not only tuberculosis, please evaluate for all these etiologies. Never forget nocardia. This is often missed one. Okay. Second one is, entity of necrotizing pneumonitis, means severe bacterial infections, especially our Staphylococcus aureus. Second one is oh, second one is Klebsiella pneumoniae and oral anaerobes, especially in those comatose patients who are bedridden. Aspiration can lead to necrotizing pneumonitis. So whenever lung parenchyma is necrosed, cavitary formation may happen. So especially in sick and moribund patients, suspect these agents: oral anaerobes, Staphylococcus aureus, and Klebsiella pneumoniae. Okay, got the point? Last one, which is not present in India, but of course in China and those who are migrating in Western world, this fluke, liver fluke, Paragonimus. Of course, we can neglect this thing. If at all you don't want to go to US after writing USMLE. So again, stress again. Most common one are again bacteria, including mycobacteria, fungi, and especially in hospitalized individuals or in severely debilitated elders, oral anaerobes because of aspiration, and never-ending Staphylococcus aureus or Klebsiella pneumonia also. Okay. So coming to next causative agent of hemoptysis, that is vascular etiologies. Sometimes these fistulae can be congenital or acquired, or they can develop aneurysms, especially bronchial aneurysms or fistulae. If they erode and rupture, they can cause massive hemoptysis. Second one is diffuse alveolar hemorrhage. D is diffuse, A alveolar, H is hemorrhage. Most of the times diffuse alveolar hemorrhage is not producing that life-threatening hemoptysis, because most of times it is small volume contained within lung parenchyma, but in the setting of usage of anticoagulants or antiplatelets, it may produce massive hemoptysis. So what are those etiologies of diffuse alveolar hemorrhage? Do you know anything? Usually it manifests as contained hemorrhage, often seen as ground glass opacities on imaging. Common etiologies are again SLE, systemic lupus erythematosus, some gases, especially irritants, and these pulmonary renal syndromes, where this patient will have hemoptysis and also hematuria. That's why taking history and doing urine analysis is quite important. There are these vascularities which can affect multiple systems. Whereas granulomatosis polyangiitis, previously known as vaginous granulomatosis, affects upper respiratory tract, means saddle nose deformity, classical one, with the involvement of lung parenchyma, along involvement of sometimes renal tissues, especially with the autoantibodies against C ANCA or P ANCA, please tell. Because it is a classical one, vaginous granulomatosis, you remember it as C ANCA, C, cytoplasmic, C ANCA. The antibody is C ANCA. Whereas in this related picture, but pathogenesis is different, in which again the patient would have hemoptysis along with hematuria, that is known as anti-basement membrane, B, basement membrane antibodies. Previously it is known as good posture syndrome. Good posture syndrome. For us it was very easy, but nowadays I don't know why they have changed terminology, most probably because of further elucidation of pathophysiology, but it remains the same. Here the pathogenesis is different. C ANCA, there, here it is anti-basement membrane antibodies against type 4 collagen. That's why doing urinalysis in the case of hemoptysis is very important. Okay, let's proceed to next etiology, that is malignancies. In previous olden days, if you see Telugu movies or even Hindi movies, most of the people used to die of hemoptysis, lying in the bed, and they were telling their kith and kin, if it is heroine, she is asking her husband to marry again so that he will be happy forever. These kind of emotional dramas we used to see. They used to cough up lot of blood, massive hemoptysis. Most common cause in those days, tuberculosis. Unfortunately, because tuberculosis treatment was not available, and in some settings where heroine shouldn't come back, in those movies, the director etiology is malignancy. He simply says cancer, though it is not single cancer which leads to such hemoptysis and death of a heroine, creating an emotional drama and audience having their tears running down their face. So here the etiology can be either primary or metastatic. Primary means any type of bronchogenic carcinoma, small cell or squamous, whatever it is there. Second one is metastatic, means it can be either sarcoma. Sarcoma means metastatic muscle related cancers. Another one is melanoma, cancers of skin. And third one is our usual solid cancers like breast, pancreas, ovaries. They also can metastasize to lung parenchyma and can produce on erosion hemoptysis. Okay. So if you see a case of massive hemoptysis, especially more than 40 years of age with risk factors, suspect these malignancies. We'll go to next point, that is mechanical, happening especially in children and young adults. One is accidental or intentional inhalation of foreign bodies, especially vaping, VAPANG, vaping. Though vaping can produce this one, that is diffuse alveolar hemorrhage. So sometimes associated solid substances, they can erode through bronchial walls, can lead to hemoptysis. In addition, ever increasing procedures of bronchoscopy and also procedures on the heart, especially on left atrium, or catheterization of a pulmonary artery, they can lead to inadvertent rupture and bleed. So these are iatrogenic causes. So these fall under the category of mechanical causes of hemoptysis. Last one is endometriosis. Endometriosis is nothing but aberrant location of endometrium in various organs. It can be in liver, GAT, like in lungs, wherever it produces bleed. It is known as catamenial bleed, CATAMENIAL, catamenial bleed. If the woman is having regular menstrual cycles, every month if the woman has got hemoptysis, suspect endometriosis. Of course, this is one of the rare etiologies of hemoptysis. Got the point? So briefly, this is going to summarize various etiologies of hemoptysis with emphasis on infections, especially related to tuberculosis. Okay. So dear students, so far we have discussed various etiologies of hemoptysis. One point I would like to tell, most of the times patient won't die of exsanguination, means completely losing his entire blood, rather of obstruction in the respiratory system itself. If a patient is coughing of blood around say 150 ml, it is very dangerous situation. First, protect his airway, that is most important. If at all, if there is any take home message, if you suspect massive hemoptysis, protect his or her airway, ideally with intubation. Okay. Next step is only controlling of blood source, whatever it is. Let's go to next slide. So this is the management part. So we have defined hemoptysis as massive versus trivial, but it is equally important to assess the patient with a proper history and physical examination, either with risk factors or no risk factors. So what are those risk factors? Age more than 40 years, smoking history, any other previous lung pathology, cardiac pathology, or other comorbidities. So most of the patients fall in this category, that is with risk factors. So in such settings, take one chest X-ray to assess unilateral if any, one hemogram sample. Though spuriously hemogram can be normal in acute settings within first 24 hours, because it takes time to develop hemodilution in such settings. And never forget coagulation studies, CT, BT, INR, kind of those things. So platelet counts already revealed by hemogram. In addition, we are doing complete urine examination, that is urine analysis I have told earlier, as stressed upon this urine analysis to assess hematuria, kind of those things, and also kidney function test. Okay, these are the basic tests: hemogram, KFT, coagulation studies, chest X-ray. You remember all as CCCK. That's it. All starts with K, like that. If at all there are no risk factors, what I have to do? Don't leave the patient. Follow up serially. Observe every 6 hours. If at all it is not life-threatening, assure them. Assess whether it is really pseudohemoptysis. Pseudohemoptysis is nothing but hematemesis and epistaxis. So in such settings, assess for their local causes. Okay. If at all you find out any infection in minimal hemoptysis with no risk factors, treat with appropriate antibiotics or antivirals. Got the point? Second thing is, in the setting of risk factors, you have done these investigations, then go ahead with CT chest. CT chest, if at all you are combining with the angiogram, it is going to pinpoint the lesion where it might be, mostly in the bronchial vasculature, that I have told. So this is for non-massive, and if required, you can do flexible bronchoscopy at later date to find out the exact etiology and pathogenesis of non-massive hemoptysis. Clear? Here, these are compulsory but not urgent. On other side, urgency or emergency lies here. First thing is protective airway. If it is unilateral, intubate the patient and please lie down the patient on affected side so that blood won't gravitate to normal side. Sometimes after intubating, mechanical ventilation may be mandatory. Once patient hemodynamics are stabilized, then assess for embolization. If already CT angio has been done, well and good. But in acute settings, doing embolization is one of the risky things, but invariably one has to carry out sooner or later. So either with the help of intervention radiologist or per se pulmonologist. Okay. In very rare settings where we can't localize the source of bleeding, then one has to call CT surgeon into the picture. But the catch here is that already when surgeon has arrived, patient condition is in jeopardy, moribund. So surgery is usually not advocated in such settings. So in the setting of massive hemoptysis, this is the sequence: CT angiogram. If flexible bronchoscopy is available, please do it. And especially it is helpful in suction of the clot. At the same time, you can insert a balloon catheter or a blocker to stop the bleeding source, along with local measures like either the ICID saline or epinephrine. In addition, tranexamic acid is helpful as a local instillation. So these are the measures carried out by pulmonologist. On other hand, CT angio has been done, flexible bronchoscopy has been done, and you have found out a lesion. Most of the times in 80% of settings it is due to bronchial artery. Embolization has been done. If it is successful, well and good. On other hand, if bleeding persists, what to do? Most common reason for persistent bleeding is not treating underlying pathology. In such acute settings, one has to resort to rigid bronchoscopy with cautery or organ plasma coagulation. This is the sequence. If at all expert interventional pulmonologist is not available, then one has to call CT surgeon. But remember, mortality in such settings with surgical procedures is very high, around 50%. And role of CT surgeon is essentially to protect the whatever that remaining normal lung, not to save the diseased lung. Okay. Thank you very much.